Hello and welcome to the second session of the second day of the Rapid Evaluation in Healthcare Conference. I'm Sarah Blundell, the head of the Improvement Analytics Unit for NHS England and Improvement. This panel session will address the topic, how can we embed rapid evaluation into a learning health system? On the panel today, we have Philippa Darnton. Philippa is Associate Director of Insight at Wessex Academic Health Science Network. She has nearly 30 years experience of working in the health service and academia, and she currently leads a team of evaluators providing independent studies of innovation in healthcare. We also have Lawrie. Mike is Director of Health Evaluation and Advisory at Ipsos Mori. He's working in their public affairs group to grow their existing health evaluation work. Mike is also currently building a new area of work for the company, providing analytical advice and support to the NHS. Joining them is Dr. Angelique Mavrodaris. Angelique is a consultant in healthcare public health at Public Health England and a clinical research fellow at the University of Cambridge. She has led the development of the East of England Population Health Research Hub, and further to her applied research role, Angelique walks across regional health and care systems to further inform strategy on prevention and health inequalities. And lastly, we have Mike Woodall. Mike is the Integration Analytics Lead at the Strategy Unit. He has over 20 years of experience of managing and analysing data across commissioners and providers within both health and social care. And Mike currently leads a team which specialises in quantitative evaluations and linked health and social care products. Today's session will also involve you, the audience. So we are asking you to pose questions to our panel through the chat function. And we also ask you to contribute your own ideas through the poll function. There will be two polls running during today's session, addressing the two questions being posed to the panel. Firstly, Mike will tackle what do we mean by a learning health system and how does rapid evaluation fit in? And then Philippa and Angelique will give their thoughts on what are the challenges of embedding rapid evaluation into local practice. We will also be taking the questions from you, the audience, and other members of the panel in sequence after each question. And today's session will finish with the sharing of the results from the audience poll, with that sharing being given by Dr. Stefano Conti, who is a senior statistician from the Improvement Analytics Unit. Now, without further ado, I ask the facilitator, Andy, to release the first poll, and I'd like to welcome Mike Lawrie to give us his thoughts on what do we mean by a learning health system and how does a rapid evaluation fit in? Mike?
Hi, Sarah. Thanks very much for that introduction. So, as Sarah says, I'm well, she didn't say this, but I like to think of myself as a jobbing evaluator working with my customers and clients across the NHS and the wider health and care sector. And that's the lens with which I'm going to give you some observations today on what a learning health system might look like. So when we engage with our customers and our clients, the first thing we generally the first point of engagement is a pre-tendering exercise. So our client is looking to appoint an evaluator for to conduct an evaluation of a program or a policy that they've developed. And I'll always look at that pre-tendering exercise and the terms of reference that they're putting together and try to kind of discern whether there's a really the signs of a positive sort of learning objective within that evaluation. Some of the characteristics. So I'll always look for a really clear justification for the evaluation. Not everything needs evaluating. That is the underpinning premise for that, I think. So we want to be clear that there's a real purpose to the study, and a sense of where it fits with the organisation in question, and of course also the wider evidence base. So in those early discussions or that early documentation, we'll always see, is there a literature review sort of underpinning this, or is it clearly that there's is there clearly a set of wider contextual factors being considered? I'll always look for a statement or a description of the decisions that the evaluation might inform. Often we're looking at the question, what what is my client, what is my customer going to do differently as a result of knowing the answer to the question that we're trying to answer for them. That really helps to zero us in on the most important exam question. Another hint towards an organisation that's interested in learning is it's a bit of an X factor in it's curiosity. So a lot of the tenders and a lot of the evaluations we see, they are drawn from the Green Book or the Magenta Book. These are the two main guidance documents within central government, and they prescribe a set of generalised objectives. But I'll always be keen to see if the organisation is, are they curious about a particular impact on a particular group, or are they really trying to delve into the contextual drivers of something that they want to observe. So it's that X factor of curiosity. And then finally, this is another slightly sort of high level comment, but I'll often look for what the prevailing climate, as I like to think of it, what's the prevailing atmosphere affecting the organisation or the programme in question. Let me try to make that a bit more real. So an example of a client I'm working with at the moment, which is quite a new organisation, or a new group of people working on a particular healthcare challenge. And what's fantastic is a lot of the work they're commissioning at the moment is quite process focused. They're asking us to really try to help them establish how they're going to operate in years to come, and using evaluation to do that. Is there another example? Is the prevailing atmosphere of that organisation, is it one that's quite risk averse or focused on assurance or regulation, as opposed to therefore by implication lacking in some respects the opportunity to explore a policy or a question in a really open way? So I often make that sort of soft assessment at the beginning of a project, and I think it can be really indicative of what will be to come with the evaluation. And actually, this sort of prevailing atmosphere, I think, can change within the life of a program, particularly if it's a longer term study, a longer term program. Often you'll see a program in the early year perhaps be much more exploratory and open to flexibility. Perhaps if it's a multi-site program working with trusts or commissioners around the NHS, those groups will have a longer leash in the early years of that program to apply an intervention in a way that suits their local area or local population. But perhaps as time passes, a program might tighten and zero in on a set of outcomes or a set of core outcomes, and the opportunity for experimentation might reduce. So I think what I'm trying to say is that a learning health system can alter even within the same program over time. A couple more thoughts on what might constitute a learning health system. When I get down to the intervention or the program itself, there are decisions that will have been taken about that intervention, which I think really indicate whether the extent to which the principles of learning have been adopted. Most crucially, I would say the extent to which a program is designed to be evaluable. Obviously, there's a set of early choices that can be made in the design of an intervention, like a plan for the rollout of a program, which can make it easier or harder to evaluate impact, or embedding a minimum data set or expectations around data collection. If these things have been done, I walk in and I think, we've got a good chance of doing something really robust here. And if they've not, then that obviously presents us with a set of methodological challenges to get over. And then finally, that intervention, how novel is it? And obviously, it doesn't have to be something completely out of the blue, but there's always got to be something different about the program to demonstrate for me a client or a customer seeking to capture those characteristics of a learning system. And novelty might be about scale. So novelty might be the novel thing about this program is that it's doing something that's only been done in small areas over a big area. But I'll always look for that word, that notion of novelty.
Brilliant. Sorry, Mike, I'm having to cut you off there.
Yes, of course. Thank you.
Brilliant. Thank you. Can we head over to Mike Woodall now? Would you care to share your thoughts on this question?
Sorry. Thanks, Sarah. So I work at the strategy unit, which is a team of quantitative and qualitative analysts. So I mainly work in quantitative analytics. So I'll kind of answer it from that side of the kind of fence, but we're looking at kind of mixed methods of evaluation to get the most out of this. So in terms of what I think a learning health system is, and I think the NHS and the new ICSs should be learning health systems in order to get the best out of outcomes and the best use of resources. So learning health systems, I think, learn from both within and outside the system. So they're bringing in evidence from outside and then testing that within the system. They're looking at things that have worked within one part of the system and looking at how they might kind of be able to be moved to other parts. They need to be open and honest. So we learn a lot from our mistakes, or as much from our mistakes as we do from our successes. So being able to publish those mistakes and being able to kind of learn from them is really important. And from that, publishing all your findings where possible, publicising those findings, making sure that other people can learn from them. And within that, so from a quantitative point of view, using things like open source tools allow you to publish the code that sits behind them. So people don't just learn from the actual evaluation, but they learn from the methods. And within that, the strategy unit are working across the Midlands to develop things called decision support units. So these are within each of the STPs in order for them to develop better decision-making processes and to learn from each other. And we're providing that network to help them, along with a set of training and kind of support to do that. And, in order to learn, you need evidence to show that things work, and analysis to spot where you've got problems so that you can kind of develop those. And this is where rapid evaluation can help with that. So in terms of rapid evaluation, it improves, it informs improvement cycles and provides real-time learning into the system. And it's much quick. You're looking at things that report back on monthly or bi-monthly, rather than going away for 6, 12 months or years and then coming back with the results. And for that, you need to include kind of formative evaluation, so evaluation while it's happening, as well as elements of summative evaluation. And again, a kind of mixed methods where quantitative evaluation might tell you why something's worked, but the qualitative helps you kind of understand the mechanisms that delivered that and how that and how it was implemented, and those elements are important. But that said, complex quantitative studies don't always lend themselves to these quick evaluation cycles. So agreeing metrics that measure things like implementation and process are important. So actually the constant monitoring of the change during the implementation is important. And we've developed metric measurement elements to do that elsewhere, but they can provide early insights into whether any intervention will work. And then if we kind of go back to the start, we've done quite a lot of elements around design stage evaluation. So things like feasibility studies at the start of of this to understand not just whether the intervention will work, but whether the evaluation method you've chosen will work. So, what sample size might you need to actually show an impact based on a set of potential impacts based on a set of modelling of what it might do, and then ultimately when might you be able to run the evaluation, a kind of full quantitative evaluation to do that. So it may be that you've got enough people going through your system to do something within 6 months, but it may be that you've got relatively small numbers and the impacts aren't that big that you need to leave it a bit longer. But again, those process measures, those implementation measures will tell you whether you're on the way and will enable you to kind of modify your approach to your implementation. And it's really important you involve the kind of managers and clinicians at the start, and that you fix your methods for your quantitative evaluation. You don't kind of want to get to the end and start having people alter it to find an impact. So it's being clear and upfront with them on what the impact of those are, and also getting them to be upfront about what decisions they'll make. So what evidence do they need to carry on with an intervention, stop an intervention, or scale it up. A mixed methods evaluation, as I said, will help you understand the mechanisms as well as the actual elements of that. And it's really important then, if you kind of bring that back to learning health system, that local people understand the methods, so that, as part of our decision support network, we're providing training to local people on quantitative and qualitative evaluation methods, and providing training into leaders that will allow them to kind of respond to the results of evaluations. And we've also developed a set of tools, including a kind of easier to read evaluation guide that allows them and supports that. So I think it's really important that you teach, that you help people understand how evaluations work and how those results will come back.
Brilliant. Thank you, Mike. So we're at the stage in our session today where we go to questions from the panel and from the audience. So if you have got any questions from the content so far, please feel free to put them in the chat and they'll be pushed to me as the chair. In the first instance, I'm going to go to questions from the other panelists. So Philippa or Angelique, would you like to come in with a sort of a follow-up question or discussion point for Mike and Mike? Feel free to unmute yourself.
I have a question, Sarah.
Yeah, go for it.
I'm particularly interested in the use of evaluation formatively and how that can be done within the rapid timescale of a rapid evaluation. And the methods that Mike's used to do that, and that might be interesting to explore.
Which Mike?
Either, but second, Mike, you talked about that just at the end of your talk there about the techniques that you've developed in your unit.
Okay. So we're doing a lot where we're training individuals within systems to do some of the qualitative evaluation work. So that interviews are done by people who work in the system, so that they can get into the system easier and can respond back quite quickly, and it increases their capacity and increases the way that they do. And we've been helping them to kind of understand those methods. We've developed sort of detailed analytical kind of plans at the beginning of projects. So, as I said, quite a lot of elements around process measures. So we're doing a large-scale evaluation of a large-scale cancer programme for NHS England and Improvement. And within that, we're doing kind of regular reporting on some of the processes, so whether they're being able to get out to the people that they said they could do. So there's a theory of change that sits behind it, and we've got a measurement framework that sits from that theory of change that says, if you invite people to this program, if they come for their initial check, if they come for their treatment, then this is the impact. So you can measure those time points, and you can measure the distance between those time points. So that's important. And we're also looking at when we can then apply more kind of technical methods. So you can look at things like statistical process control to apply over the top of those to look for kind of variation, and we can benchmark across different projects within that program. And then we're looking at when we might be able to run sort of more quasi-experimental study designs to actually evaluate the program. And a lot of that sits within that design stage. So what's the feasibility of doing this? When do we think, if the impact is as expected or within the confidence intervals of what is expected, when are we likely to evaluate?
Brilliant. Thanks, Mike. We've got a few questions here from the audience, so I'm going to key one of those up. So we have one from Johnny Dance from NHS England and NHS Improvement, which is saying, it's been said not everything needs to be evaluated. Most will agree. However, this is one of the major pushback evaluators face when promoting the role of evaluation in a culture of can't we just get on and do. Can the panel share their experience on where to agree to draw the line between what does and doesn't need to be evaluated, and how can this be used to pitch potentially resistant audiences? Michael, do you want to come in on that one?
Yeah, let me try to answer that. And obviously, there's I don't want to do myself out of a job and cancel all evaluations from here on in. But I think so. Let me a set of characteristics again that you might want to look for. So, is something kind of that point about novelty, and novelty doesn't just mean that the intervention has been sourced from somewhere far away and brought into the NHS. It could be something about scale, or it could be something about a particular group that's being focused on. So I would argue that there should be a degree of novelty. There's a good evaluation. There should be a sort of a knowledge gap that's being addressed as well. And I often, that knowledge doesn't have to be sort of the standard knowledge generated by research. It might be kind of that sort of service, very pragmatic, very prosaic type of knowledge, such as, how to deliver an intervention over a population that's 200,000 people as opposed to 20,000 people, or how to deliver something in 10 places and not one. So there's a couple of, potential qualifiers for conducting an evaluation. I think final comment is there's almost like a value for money type of assessment, isn't there, in any design and commissioning of an evaluation. Obviously, if you're bringing in an external evaluator, there's a fee that would need to be paid. There's people's time in taking part in an evaluation. The clinicians or the managers who are going to support that. So, there's you almost want to do some sort of an economic weighing up of the worth of that study. Oftentimes, and I think most people on this call would agree that would, hopefully fall into the yes, let's go for it, let's commission or let's conduct some sort of evaluative work. But yeah, I do think a sort of upfront value for money or return on investment type assessment might be a worthwhile consideration.
I'm going to try and squeeze one last question. This is sort of for across the panel. So what workforce changes, if any, within primary and secondary care are needed to ensure monitoring, rapid evaluation, formative evaluation is possible at this larger scale that we've been talking about? Do we need more analysts within trusts? Do we need more external evaluation partners in cases where health organisations are unable to resource their own evaluators? Sort of gut response from across the panel to that one. Mike, since you're on camera, do you want to go first?
I presume that's me, Sarah. Is that?
Yeah, sorry.
Two mics.
Yep.
Oh, crikey. Well, I know the Health Foundation has done, leading work on this, trying to map that analytical workforce, trying to get a grip of who's out there, what are they working on, what sort of skills do they have, where do they sit in relation to the board and the senior decision makers. And I think in general, the view is that there's perhaps not quite enough analysts out there. There's a series of professional challenges are often faced. But I get the sense that the tide is tipping and the tide is turning, and there's a bit more organisation amongst that workforce through the professional body, and obviously the worth of the analytical community in the pandemic response, I think, has been second to none. It's been truly impressive to see the speed of the response. So I think continuing to boost that workforce, suffusing them throughout the system, whether that be in primary care networks. I don't know whether there could be analysts placed in those sorts of settings or working across an integrated care system, for example. And I think make sure that definition of analysis is not narrow. Very bluntly speaking, it could involve qualitative work and quantitative work, although obviously there's probably a leaning towards the quantitative on a lot of questions. But generally an analytical mindset, to put someone asking tricky questions or coming up with sort of ways of methodologies of gathering data to answer some of those questions. That's a mindset that I think is very specific to a group of people, a group of professionals, and I think we should support that more and more.
I'm afraid we're going to have to move on to the second part of our session now, so maybe we can come back to that question later on. So thanks for those questions, and the discussions raised some interesting points that I'm sure, as I say, we're going to want to discuss in more detail. We need to move on to the second question for our panel, and so I invite Philippa Darnton to sort of give us her thoughts on the question: what are the challenges of embedding rapid evaluation into local practice?
Thank you, Sarah. Good morning, everyone. So my reflections come from experiences in Wessex, as Wessex HSN undertaking rapid evaluations, and during COVID in the past year undertaking a number of rapid insight projects with our members to understand their experiences of responding to the COVID crisis and to help them to think through the changes that they would like to keep or stop going forward. So I've got 4 key challenges to reflect on with you today. The first of those is around the resource-intensive nature of rapid evaluation and the importance of relationships. Clearly, when you're undertaking an evaluation in a very quick period of time, you're having to put a lot of resource to that work. We've found that we've needed to put a number of evaluators on the project, and often those with experience in order to rapidly understand the data, analyse the data, and turn it round in such a short period of time. It's also, of course, a time that puts a lot of pressure on clients in terms of them recruiting staff and users to be able to speak to the evaluators about their experiences in that qualitative field work. So the relationship between the evaluator and the client is absolutely key here. And my colleague Andrew Sibley describes it as a symbiotic dependency. To get this job done quickly requires both parties pulling together. And for that, there's a real advantage in having evaluators who are embedded in the system, who understand the relationships, and can really work quickly to maximise the efficiency of a rapid evaluation piece of work. The second area of challenge is around concerns about the acceptability of evidence that is generated so quickly, its validity, its generalisability. We have addressed this by making sure that client expectations are really well managed from the start. So a couple of the speakers earlier today have talked about the importance of getting the questions right, and making sure that the evaluation is tightly focused around the questions that can be answered within a tight time frame, so that are evaluable and are measurable, but also giving what the clients need to know within that period of time. So that scoping phase is so important, even though it's very rushed. In terms of checking for quality and completeness, that's important to do throughout the evaluation period, and of course being absolutely explicit about the limitations of rapid evaluation when communicating the findings at the end. They're often from a single snapshot in time. They're often reliant on a smaller number of data sources than you might do in a full evaluation. But clients are recognising the value of evaluation, not just for the findings, but for the process of being engaged in reflection. And we certainly saw that in one of the systems that we worked with. They felt they were brought together with a shared appreciation of the challenges they were going through in COVID, and were able to problem solve together going forward. The third area of challenge is around ethics. We know that this is less clear for evaluation than it is for research anyway. Doing rapid evaluation really throws the spotlight on ethical issues. And we've had to do some additional work around that to help systems understand the best practice that will be followed, even though that it's being done rapidly. There are no easy answers, and we're doing more work on this in Wessex to understand some possible ways forward. And finally, the translational challenge from evidence into practice. Always a challenge, of course, but in rapid evaluation, I think it puts the onus on evaluators to be especially creative about how they're presenting the findings, how they're communicating the findings, how they can make them easily accessible to all of the stakeholders. We've used mind maps to show key themes, short slide sets, very different ways of presenting results than for full evaluations, and they've been well received. And finally, just to leave on a positive note, I think rapid evaluation has opened up perspectives on the value of evaluation. As I've said, it can be a way of getting very rapid engagement and of creating opportunities for reflective appraisal. Our rapid approach was perceived to have done that by the people that participated in it. Staff saw the results quickly, and it's generated a real appetite for doing more of the same going forward.
Brilliant. Thank you, Philippa. Angelique, would you care to give us your take on this question?
Thanks, Sarah, and good morning, everybody. Just to give you a little bit of background on the work that we've done in the east of England. A few years ago, the Academy of Medical Sciences published a report that highlighted the disconnect between population health science and population health in practice. And one of the responses recommended was to set up regional hubs that brought together practitioners and academics. And this is something that PHE has been leading across the country, and across regions, the models are very different. In the East, we conducted quite a rapid, more an intensive consultation with a lot of our local authority practitioners and directors of public health and academics to try and understand where a hub and network like this could really add value. And what came back was very much around the translation and the evaluation of what worked in practice. A lot of the questions and comments that we got back were more about more sort of to the extent of, we know what works, but we don't know how it works, and we don't know how we can make it work for our local populations. And the East of England Population Health and Research and Evaluation Hub has really worked quite hard with a lot of our practitioners and academics to facilitate evaluations, predominantly in local authority interventions, but also with NHS, CCG, and other community health partners. Just reflecting on some of our experiences and the examples, I think my approach to this question, I thought about two things. And the first was reflecting on what we mean when we say, or when we talk about results of evaluation. Because in my mind, it's almost two things. It's embedding evaluation processes in practice, and then also embedding evaluation results in practice. And the embedding of evaluation processes in practice, I find, is really what then leads to the success or possibility of then embedding the results in practice. The one is dependent on the other. And this was almost a surprise finding, I think, for us in our experience in working with academics and with practitioners on evaluations, and that we just saw that much of the value added through the evaluation process often took place before results were even generated. And I think very much about a lot of our evaluations, but specifically one that we did with the local authority partner trying to evaluate their school wellbeing service, which was an intervention to promote positive mental health and wellbeing among school-aged children. And our academic evaluators and team came together with practitioners who were responsible for implementation and design of the evaluation at design phase of the intervention, which is always such a gift when it does happen that way. But it was just really wonderful to see how the robust methodology and evaluation approach that our academic leads were taking, how much that helped inform the design of the intervention and how much value that added, and also how much it really developed the relationship between our practitioners and our academics through that evaluation process. So that, I think, was very important, and something that we now have really prioritized doing from the start in facilitating evaluations going forward. The second, again, this is all before results were actually generated, was just how that evaluation process, and again, the methodological robust thinking informed implementation going forward of a lot of our interventions. And I think what really helped here was that the academics who were leading the evaluations were part of the implementation team, were invited and part of the practitioners' working groups. So really got an understanding of what the reality of practical application looked like, and were invited to attend steering board meetings and governing board meetings, and just develop that trust with local authority partners and practitioners. And I know other colleagues have touched on the importance of establishing relationships and trust. And then when it comes down to the embedding of evaluation results, I think a lot of the conversations we've had with practitioners and commissioners have been almost in a similar vein. Things like, the intervention sounds great, it's a really nice design, but how do we actually implement that? Less attention is often paid on what is needed to implement, what resources are needed, how many people are needed to do this. So where we've seen success with embedding of evaluations, it's often been where the evaluation has been able to answer some of those questions, to really examine the essential components of certain interventions in terms of and in view of implementation. And I think this is really, it comes back to that question of how does it work? How does it work? Which components work and in what setting? Because often our evaluations are trialed or understood in a particular setting. But when we're trying to scale up and share that knowledge across the region or in different localities with different populations, that flexibility and that adaptability and understanding of the elements is really, really critical to commissioners and practitioners on delivery. And this is really, I think, a strength of evaluation, where understanding what works is then almost the bridge in translating policy and bringing the policy and delivery elements much closer together. So that was just some thoughts on what we mean by results and what is a result in terms of evaluation. My second reflection was on what is a health system, and maybe you would expect this from a public health person, but in my world, most of what happens and most of what improves health is outside of healthcare. It's more about where people go to school, where people live, if people are able to access green spaces, interactions with neighbours. And just to sort of illustrate that a little bit better for you, I reflect on some evaluation work we did on a healthy aging program with local authority partners, very much informed by local community groups and local community members. It was during one of these participatory events where we were trying to understand what the priorities would be and also what our evaluation priorities should be, that one of the participants turned 90. And the group had organised a birthday cake for her. And she'd been making special tea. She was known for this. So we joked and we said, "Oh, is it something that you're putting in the tea? What is the secret to your longevity? Is it the tea?" And she laughed and she said to us, "It's got nothing to do with the tea, but everything to do with the people I drink it with." And it's something I'll never forget, because I think this is sometimes and often where we lose traction in evaluation or in trying to understand or decide on priorities for what interventions should be doing and therefore what we should be evaluating. We lose traction with the populations that we serve. We lose traction with the agencies that represent them and with often commissioners and decision makers who are all trying to improve health and what that really means to people.
Sorry, Angelique, I need to cut you off because we need to go to questions. Apologies.
Wow. I think it's just in summary then to say the breadth and complexity is something that evaluation needs to be reflecting.
Brilliant. Thank you. So we do have a question for the panel. This is from Elizabeth Fisher from the Nuffield Trust. What do we need to do to make the National Health Service a learning system rather than make local services a learning health system? Mistakes and scandals seem to occur again and again, e.g. in maternity, and the NHS doesn't appear to learn from extreme negative events. So how can we expect it to learn from smaller positive results from the other parts of the country? So maybe people want to bring in sort of their local experience here about, how we are sort of escalating up local initiatives and promoting them, and whether or not the NHS is capable of being a comprehensive learning system. Does any of the panel would like to come in on this question?
I think this relates, it was a reflection I had on the workforce question earlier about who needs to be, who is critical to delivering a learning health system and responding to the results, participating in evaluation. And I think that whilst, of course, everybody has a responsibility and we want to get the whole community engaged here, that champions who understand the value of evaluation and the value of the learning that can be gained are key stakeholders in this. And certainly locally, we have some very key clinical champions, not necessarily senior staff from across the whole staff mix, that understand the value of evaluation and learning and have been really important in getting that utilised to the benefit of everyone.
Would anyone else on the panel like to come in on that question?
Mike?
So I think, as Philippa said, it's important that the decision makers understand the evaluation process and are able to work from the results. And I think it's also important that we publish and kind of promote all our results and all our information across the system, so that not a lot of learning is held within organisations, and it may be promoted within those organisations, but there's not that. But people don't seek to kind of get that published and out to the wider world. And I think from there, it's really important that we publish both our positive results, so when we see that things have gone well, but we also sort of celebrate where things haven't, and we promote that, because there's a lot of learning to do that. And it may not be that the central idea isn't kind of valuable. It may be the implementation that was the issue there. So being upfront and kind of and getting those messages out is really important, and getting them as widely disseminated as possible. So maybe looking to peer review publication where we can, more from within the system, just to make sure that that learning's available to everyone.
Brilliant. Thanks. Go for it, Angelique. Yeah.
Just to add, because I think we've highlighted the importance of relationships and trust between different partners. I think we've also talked quite a bit about alignment in priorities, so to understand what each group's priorities might be. And I think it was yesterday that Judith talked about social responsibility. We're dealing with scarce resources here. So I think as a priority and as a culture, how we use and utilize those resources needs to be something really important and something we put at the forefront of our decision making.
Brilliant. Thank you, Angelique. So we've reached the part of our session where we will move over to, and I'd like to welcome Dr. Stefano Conti to join us for these last few minutes to share the views from the audience polls. Stefano, would you please share what you found?
Indeed, Sarah, thank you very much, and good morning, everybody, and thank you for our panelists for kickstarting the conversation. Some very interesting topics, I should say, across the board. I will just draw from a few of them, necessarily given the constraints of time. So a couple of them have got to do with the responsiveness of the health system being evaluated. It emerged a requirement as well as a desire for the system to be responsive to the evidence that's been generated from an evaluation, and also to act in an iterative, mature fashion. As participant stressed the consequent link between testing, learning, acting on the learning. I thought that this was particularly rich as a consideration. A few other points were made about inclusiveness of all parties involved into evaluations, notably but not exclusively of staff, as well as the requirement of keeping the whole evaluation process top to bottom lightweight. I would say, in fact, it needs not to be burdensome to facilitate the learning. Something that also emerged is the importance of buy-in, and this emerged across the two questions being asked to participants. Buy-in is seen as a key requirement, again, from the senior management team down all the way to the staff on the ground. Importance of relationships between the client and the evaluator, as well as alignment of priorities, as Angelique has just stressed, for instance, are also seen as fundamental requirements for the success of a rapid evaluation and its embedding into the system. Another couple of considerations have to do with making sure that resources, as scarce as they are allocated reasonably, and in particular in consideration of limited time that an evaluation is afforded in order to produce its findings. Lastly, I would like to stress the recognition of the importance of the connection between the findings from an evaluation and the context within which these findings are to be grounded and expressed. The key operative word being the importance of the so what question being formulated so that it's meaningful and it can then, once answered robustly, be used in a fruitful manner. I would say that these are the key themes across the board.
Thank you, Stefano. That's really helpful to hear that. So this brings us to sort of the end of this panel session. Can I just take this moment to thank our panelists, Lawrie, Woodall, Philippa Darnton, and Dr. Angelique Mavrodaris, for their contributions and the interesting discussion today. I think there's obviously a lot of points here that probably we'd like to do further discussion on over at the discussion wall. Thanks also to our chat moderator today, Florence Starr, obviously our pollster, Dr. Stefano Conti, our facilitators from Glasgow's, which is Andy Ray and Vanessa Marshall from the Nuffield Trust. And lastly, thank you to you, our audience, for all your attention and engagement today. It's been really interesting. Thank you.